Okay, good morning, everybody. We are here. It's time. Let's go ahead and get this rodeo started. So we have a session for you, but before we do that, there's always that housekeeping we do at the beginning, and I don't think I have a slide that tells you the word, but I will tell you the word. The word for this session is branch. B-R-A-N-C-H, branch. That is our word for the session for your CEU credits and so forth. So, that's it. You all know about your attendance verification forms, so you're pretty good. You're set. My name is Matt Fury. I'll be the moderator for today's panel, and because I just learned about the technology limitations such as 1 microphone and 4 speakers, I am probably, after I finish this little intro, going to hand it over to our associates over here who are listed on this sheet right here. We've got Dr. Wiley Patterson over on my right, and I believe you are from San Antonio.
Yes.
And I'm going to let him tell you a little bit about himself. Then I have Dr. James Lai from Houston, Texas. And I also have Mr. Rick Green from San Antonio as well. And we collectively want to address a subject that is near and dear to our hearts because it's something that actually everybody works with if you work in the substance use disorder arena. We're all dealing with this particular issue involving opioids. So today's panel is really as much about you as it is about the answers that I hope the panelists can provide. Each of them probably will have an introductory statement or part of a presentation. I'm going to ask each to give a little bit of background about themselves, what they do professionally, and how they're involved in this industry or this treatment. I call it an industry, but anyway, the treatment field, the field of helping people recover. And so they will do that, and then we will launch into questions and answers and thoughts and ideas. And again, we'll be interested in your questions and ideas as well. I will just start by saying, as we say, the opioid treatment panel, this panel of individuals, all of the people up here work in the treatment profession and serve people who struggle with addiction. And opioids are front and center in that work that everybody does. And so, since there's so many varied approaches to how we can address the opioid problem, especially from a medical, a behavioral issue, and so forth, I think it'll be interesting to hear those perspectives. I'm Matt Fury. My background is I am a licensed chemical dependency counselor. I've worked in the field almost 40 years and worked with people with addictions. Currently serve in an administrative capacity and run what is called Foundations Recovery Network, which is a series of treatment organizations around the country that provide services to people with behavioral health challenges. And that's what I do. I'm also, as you know, very involved with NADAC, and I'm going to turn it over to Dr. Patterson and let him start and tell us a little bit about himself, and then we'll go from there, and then I'm mic free the rest of the time. Here you go. Hello.
Morning, everybody. My name is Wiley Patterson. I graduated from medical school in 1978, a long time ago. I've been doing addiction work since 1983. My addiction practice is an outpatient practice in San Antonio. It's abstinence oriented, so everybody that comes to me has to kind of agree we're going to work toward that. Maintenance is a fine concept for a lot of people, but I usually let somebody else do that because it's enough work getting somebody abstinent. I also do a lot of work with opiate addicts. We do some naltrexone implants, which helps people be abstinent, but there's also the group of people who get addicted to opiates once they're adults and they have a pain problem like a surgery or car accident. And when they come to me pretty much ready, they want to get off this stuff, I have about a 90% success rate. I learned some other alternative therapies over the years, one of which is called rolfing. Most people haven't heard of it. And I also do something called osteopathy. Both are manual manipulations. And they can be pretty effective if somebody learns to do that stuff well. So I'm able to get people out of pain pretty consistently. And when that happens, their mindset about using opiates changes pretty quickly. Some people are really ready to leave them. Other people are a little more addicted than they ever realized. But again, they're in the right place. So that's my practice pretty much. Thank you.
Hey guys, my name is James Lai. I'm from Houston. I After I graduated from medical school, I wanted to become an anesthesiologist and specialize in pain management. And that was up and coming specialty at that time. And there was a lot of interest in managing pain. And I did that for the first 15 years of my practice. And prescribing opioids, that was just one of the tools that I used. And I can tell you it was very effective, and practically everyone in my practice is on some sort of opioid at one time. Well, that all changed about 5 years ago when addiction hit home. And I found myself sitting in Al-Anon meetings for about a year and a half and come to know addiction pretty well. And because of that experience, I have looked at chronic pain from a different perspective. It's no longer about helping people numb the pain sensation, but rather get to know the people and know where they're hurt, that brokenness of their soul and so forth. And so that's what I do now. I started incorporating addiction medicine in my practice. The pain management part, I'm still seeing patients for chronic pain, but it is more of a abstinence-based chronic pain management. We help people get off opioids, do a lot of counseling. We'll promote CPA, chronic pain anonymous meetings. So that's where my practice at right now.
And you're also board certified in addiction medicine.
Yes, I just got myself board certified in addiction medicine as well.
Triple board certification. That's great.
Fortunately.
Great. Hi, everybody. I'm Rick Green. I'm a chemical dependency counselor in San Antonio. I'm also on the public policy committee for NADAC. Opiates are my passion, and I helped co-author the public policy position statement on opiate treatment. If you haven't seen it, it's online. It's on our website. Matt and I have been talking about this for more than a year. He's given 3 presentations on the crisis, and it's been very well attended and very well received. It's a real honor for me to be here. First of all, this is my 6th NADAC national conference in a row, and I always dreamed about being in a breakout session and presenting, and finally I'm doing it. So thank you guys for being here. Thank you for coming to Houston. Thanks for letting me present or be part of this panel. Something Matt and I wanted to do was begin to talk about some of the more deeper issues, maybe the more controversial issues, maybe more the emotional issues. That's one thing we might be able to touch on here. In my past life, I was what would be called the worldwide director for a very large pharmaceutical company and a very large brand. And what I feel is happening is there's an overemphasis on communication promotion with some of the replacement therapies, both buprenorphine and methadone. When a drug is branded or there's intellectual property, there's money to be made. And hundreds of millions of dollars are being promoted to both research and promote these medications. And I feel like abstinence, even outside of the opiate realm, is somewhat under attack. And many colleagues feel like that. We also feel, of course, that naltrexone, Vivitrol, and other naltrexone preparations don't get the voice in this battle or in this debate that it should. And I hope we can kind of bring forth some of the other side of the issue, because it seems to be very heavily tilted at one point. The other reason I hope to be here today was that there's a lot of new breakthroughs in opioid treatment. Hopefully some of you saw Dr. Patterson's presentation. There's a lot of new stuff that really helps the opiate addict go through very comfortable detox, and how important that is to us as counselors to start them down the road in a comfortable manner so we can start building therapeutic alliance and not traumatize them through the detox process. There's a lot of things that can be done to maintain their abstinency and prevent overdose and speed up the brain repair and handle and help us as counselors handle the anhedonia and the acting out and the misery that we see some of our opiate patients be, our opiate use disorder clients be in long-term settings. So a lot of new stuff. I hope we can get into that today. Maybe we can get into voicing both sides of the battle on the medical assisted therapy front, and that's why we wanted to have this. Maybe we can cover it in an hour and 15 minutes. Maybe we can't, but Matt's pretty good. He probably can do it. So that's it.
Here, I'll just come over here.
Come on over here. You want to turn that off?
You could.
Sure.
Or yeah, it's fine. It's cool. Everybody good.
One of the things that, since you brought up, and there was a lot of discussion about a move away from opioids as a primary treatment both for pain but also for being the focal point, at least for this group's, this panel's treatment approach, there's not as much emphasis on using medications that are such, agonists such as buprenorphine or methadone in the practices that you have. But there clearly is a place in the treatment canon for those medications. Let's start with Dr. Patterson. What is your thought? What are your thoughts on where that fits in treatment, and what some of your ideas on when the various approaches can be used, and when you would recommend or not recommend at all? Thank you.
I remember back in the 80s, I was first being introduced to methadone, and I thought it was an outrage. It was all about abstinence. Let's get them in 12-step meetings and all that. But I realized how much more functional so many people are if they're on methadone. And it's true, they're able to work, and a lot of things improve socially. However, I think some people are going to be on that the rest of their life. If somebody's been doing heroin for 20 or 30 years, they usually don't recover very far. It's a tough thing to get off. There's so much damage, most of which is now, after 20, 30 years, unfixable. People do function better on methadone than they function on heroin. Buprenorphine, they function better on that than they do on methadone because you don't get quite as high. Another example of this is if a woman is addicted throughout her pregnancy on heroin versus methadone versus buprenorphine versus not addicted at all, birth weights change dramatically. Methadone babies weigh 500 grams more than a heroin baby. Buprenorphine babies weigh 500 grams more than a methadone baby, and abstinent babies have normal birth weights. So obviously, buprenorphine is healthier in the system than the methadone, and way healthier than heroin. So people function better than if they're on heroin if they use these other medications. Some people are never going to recover, and that's just a given. Other people can. They try. I know that everybody thinks about being sober. What would it be like to have that again? But sometimes they've been in the trap for so long they can't picture it, or they've tried and they fail so many times, they begin to believe these failure experiences more than anything else. But when I think about it, I know about abstinence. I mean, as a physician, I learn a great deal about what gets wrong with people, all these pathologies. But in all these years since '78, I've learned a lot about how to get well. I went to something called Rolfing School. Many people haven't heard about that. I've been a Rolf for a long time. They taught me so much about normal function. I mean, it made me mad at times. I mean, why didn't I learn this stuff beforehand? But I learned it, and it really changed my perspectives about what I have to offer. So when I have somebody come in new, I kind of go as a default to what would I want for this person if it was my family member. Here's your methadone, here's your buprenorphine, or what about let's work toward, even though it's really challenging, getting your entire self back. So that's what I decided to focus on because it's hard enough. But again, I really think there's a place for methadone and buprenorphine both. I use buprenorphine all the time to taper people, sometimes over a week or a couple of weeks. Sometimes I've tapered people over a couple of years. I have a guy about 30 who was on heroin. His anxiety was so high, going any faster would not have made sense. He could not have succeeded. But he's off. He's off of it altogether. He smokes dope every now and then. Now we're going to start the benzo tapers, but he's making progress, and his psychological competency is way, way above what it used to be. So it's hard. You have to learn a lot about, Dr. Lai just mentioned going to Al-Anon meetings. I go to Al-Anon meetings too, and I would say it was probably one of the biggest tools in my toolbox about handling addicts because I begin to rethink things a lot. It isn't a very logical process. It's a very emotional process, and you have to learn how to not get drawn into these things. And you have to learn how to allow them to be at the stage they're at and show them the next small thing they can do to succeed. If they have a series of successful experiences, they're going to listen to you and they're going to ask you, what's the next one? That's a slow process, but it's an effective one.
Dr. Lott, you want to address
tattoo, maybe? Some ideas of yours?
Okay.
Is it appropriate wear?
Wow. That's a loaded question.
Right.
Let me just talk about chronic pain, what chronic pain is all about. Let's start with that.
Okay.
Most of the people I see in my office, they come in with some sort of injury. That's how pain usually starts, is with an injury. Now, chronic pain by definition is an injury that it's a pain that lasted beyond the periods of healing. And typically we say that's greater than 6 months. And by that time, testings, X-ray, CT, MRI usually does not correspond to the level of pain the patient is experiencing. And by that time, they have failed many different treatments, even surgery. And by that time, they're usually dependent on opioid. So by the time a patient comes to me, they're usually gone through many different doctors, many different clinics, and maybe on opioids for quite some time. So I was part of that pain treatment, world where you put patient through, injections, procedures, therapy, and switching one opioid to the other, and that seems to be the cycle that a lot of chronic pain patients going through. Now, when it comes to opioid, how does that affect a chronic pain patient? Well, I look at chronic pain like this. Most patients come in with chronic pain, had a musculoskeletal injury, and they usually don't let it heal properly. They have this urge to get back to work. They have this compulsion to keep doing what they're doing. And if you look at chronic pain patient, a lot of their characteristics are very similar to a substance abuse patient. They hold work. They hold work. The value of work supersedes everything else in their life. And that repetitive work habit, work style, is what often end up, with injury, such as a bulging disc, such as pinched nerve in their back, and so forth. And so, in my opinion, this is my opinion, I think chronic pain has its roots in behavior addiction. And so, if that patient with chronic pain that has that behavior addiction come to see pain management, and you give them opioids, wouldn't they just heighten the level of their addiction? And so is there a place for opioid in chronic pain? Acute pain, yes. Long-term chronic pain, I don't believe it has a place in it. And so what do I do with people that's opioid dependent coming to my office? Well, that is a challenge for me every day. It's to get them to buy in, get them to engage. And some people I do continue to prescribe just so that they can have the opportunity to hear a different perspective, have the opportunity to maybe choose a different route. And I do use buprenorphine in opioid dependent patient so that they can alleviate some of their acute craving in between doses. But I think the key here is to recognize, for me at least, to recognize that chronic pain is not just masking their symptoms. Look for that underlying addictive behavior that's ongoing, and that may be going on for many years. Most pain patients have a high tolerance for pain, and I don't think that's genetic. I think that's a cultivated behavior over years of trying to block out the pain so they can accomplish the work they wanted to do. So I do use opioid, but I use it as a bridge to get them where they need to be mentally, healthily, in work behavior, in lifestyle changes and all that. So that's where opioid comes in my practice.
Great.
I just want to really tell Dr. Lai how much I appreciate what he said. I've had pain specialists actually tell me that they don't see addiction even existing in the realm of pain. Pain is primary and addiction doesn't matter. I've actually heard that. Thank goodness there's doctors like him that know, addiction is a part of this person they're treating, and it is a long-term chronic disease that needs to be addressed. And some just don't. It's real. What's my opinion? Who is appropriate for naltrexone? Who is appropriate for buprenorphine? Who is appropriate for methadone? I would like to take the opinion out of it. I would like NADAC and NATAP and ASAM to do what we did years and years ago when panels like this convened to talk about what level of care does someone need. And we started a study called Project Match. It was a $36 million study over 10 years. We don't debate now so much what level of care someone needs. We have a scientific algorithm that will produce that. I wish we would do that. Start looking at outcomes with opiate use disorder and these various modalities, and just take the opinion out of it so we know who's appropriate for what care. Calvin McGinn, who presented a poster on the McRisk inventory, is trying to do that. He's trying to make a peer-reviewed, quantitative tool that will let us as counselors and physicians figure out who's appropriate for what. So I hope that's the future, and I'm trying to support that. I hope you'll support that as well. It will be expensive and it will take a long time. So in the meantime, what do we do? What's my opinion? I should tell you that I worked for the pharmaceutical company that invented oxycodone and naltrexone tablets. And naltrexone tablets were a tremendous commercial failure. Probably bankrupted the company. People don't comply with naltrexone tablets. So everything I think about and do with naltrexone is under that cloud of lack of compliance. No medication will work if people don't take it. And it's a huge problem in the United States with compliance of all medications. Only about 50% of prescriptions that are written in a doctor's office ever get filled. And I think that we as counselors need to do a better job of partnering with our patients and clients to make sure they're actually following medical advice. They can't do it on their own. We've got to help a lot. And I see huge emotional fluctuations in clients, whether they're taking their medications or not. And some take them because they don't think they need them anymore. And I say, that's because it's working. But it doesn't occur to them like that. They don't have that experience. I know this. If I have a homeless street addict, and I have worked with those people, schizophrenic street addict, I would definitely want them to be on methadone. That would be my first choice. If I'm working with a pilot or a cardiothoracic surgeon, I have many, methadone and buprenorphine are not an option. I would like them to be on naltrexone. I'd like them to be on some kind of sustained release preparation of naltrexone. I know, and as Kevin McCauley pointed out, pilots and physicians get the best treatment in our society for substance use disorder, the longest and the best. And I wonder, in my compassionate, empathetic heart, doesn't everybody deserve the best treatment? Probably, yeah. Probably, yeah. Is that possible to pull off? I don't know. We'd probably have to change as a society to do that. So again, it really depends on the patient type, what medications are available, compliance, the readiness to change. Where are they on the scale? I tend to see I used to be very positive on buprenorphine. I used to be overly enthusiastic before I became a counselor. I really thought it was the answer. When I looked at the data, mostly funded by pharma, I really, really believed it. Then I actually, and they don't mind me breaking their anonymity, I have their permission, both of my sons, I coerced them to be on buprenorphine. Did not go well for them. And I've counseled many patients over the years on buprenorphine and complying or not complying. And what I realized is that only about 50% will stay on that medication 3 months to 6 months, and then they're off. That's one issue. So they're not satisfied with it either. So I haven't seen anybody ever flourish in life, and I know there are cases out there where they do, where they're on buprenorphine or methadone. So my preference is for them to flourish in life. I'm very interested in people really flourishing and self-actualizing. So if I can, I tend to lean towards the sustained release naltrexone. But even that has compliance issues. So we don't know. I would love to take the opinion out of this, the emotion out of this. It does bring up a lot of emotion and heated debate in people, and I see it, especially people who are financially dependent on one method or the other. But I think to do that, we're going to need a very large countrywide study that's going to be long-term, and it's going to cost a lot of money, and our organization has got to be involved in it. So that's what I got.
Thanks, Rick. Dr. Nora Volkow has come out and now is advocating for pharma and others to do more research on finding alternative medications that can help with medication-assisted treatment, that can help treat opioid use disorder and so forth. Because one of the things that we're now starting to hear is, because data is starting to come back and all that, is that could we not find a less addictive or non-addictive medication, not an agonist, to help rewire or help address the issues going on in the brain? And the reality is that's the challenge that we're faced with, is as people look at what's out there and what therapies are available. And the fact is that medication-assisted treatment, by its very definition, or medication-assisted therapy, is supposed to be medication-assisting therapy. It's supposed to be used in conjunction with other treatment, including counseling, including support groups, and including therapy, including other treatment interventions. And a lot of times what we see happening is that those factors become segregated from the medication dispensing part. And that's one of the challenges we have. And the further rural you get, and the less providers you have available, and other challenges that you have, people's access gets impacted. They're not getting the necessary counseling, because we tend to do treatment in episodic terms, don't we? We do 30 days here, and of course some of you are going, I wish 30 days, but you do a certain amount of treatment, and you step them down into outpatient services, and you do other types of treatment along, and if you're lucky, you can get people to continue to come back for some follow-up sessions and counseling. Now, the interesting part about certain classes of medications that are used to assist people with opioid use disorder is that those that are addictive clearly have a value. Any medication that has a value attached to it and can create, therefore, diversion, manipulation, and all those other things can be a challenge. And that is why it's a highly regulated type of medication, and there's a whole process built around who can prescribe, how much can be prescribed, and so forth. And just like any other industry, there's money to be made. So there are physicians and other individuals who get involved in that, because you've got an audience that's going to come back every month for that medication. Now, I agree with statements that it is a bridge to recovery. It can be a part of recovery for people who can continue to be and live sober and have whatever their objectives and their goals are using those medications. But there has to be some way to address what is the exit strategy, what is the plan, is there one? And I think all of us, and if anybody here works and represents a methadone program or clinic, fantastic. You'll know there are some patients who've been on for multiple years, decades even, and you'll have some where it's a part of what they want to do, they need to do. And as far as addressing all the other challenges and issues in their life, it becomes something that is, again, a tool that helps them achieve and sustain recovery. And then at some point, many of those individuals decide they want something else. They want to go a different direction. So those are different things that can happen. My hope is that as a profession, as the medical side, whatever, that research can come up with some alternate medications that can really help, because we're losing too many people. And right now, a lot of the strategies that are involved are meant to collectively be effective in helping people save their life, move forward, and have a quality of life. And that's what we want to see. What I'd like to do is I'd like to ask Dr. Lai a question. You're associated with a program that has incorporated chronic pain and addiction treatment. It's combined it. And you've done a lot of work with that over the last number of years. And disclaimer here, you know, I used to work with Memorial Hermann here in Houston, the Prevention and Recovery Center, and we put together about 8 years ago a combined chronic pain and addiction treatment program. And you know, I could do a whole CEU on the value of that. I think it's great that we've married the two together, because you're treating them simultaneously. It goes back to a little bit what Rick was saying. 50% of people don't even bother to fill the prescriptions the physician gives them when they go to the office. If you treat the addiction and someone truly has had a history of and is suffering from chronic pain, and you say, I'll treat your addiction, you go see the doctor when you leave. The challenge is that most of them don't make it back to see a physician or someone who understands the process and how the two are inextricably linked, and therefore that person doesn't get what they need, and they're likely to return to an approach of managing their pain that mirrored what they did prior to coming into treatment. That is one of the reasons that we pursued that and had some success with it. But Dr. Lai is involved directly in that type of program and in that program and others actually. And so I'm interested in you sharing your perspective on how that has been effective or not.
You know, like I alluded to earlier, it is a addiction and chronic pain. Even though a lot of people look at it as two separate diseases, you know, there's a lot of commonality in there. And so I approach chronic pain as a manifestation of an addictive brain behavior. All right, so that's the beginning of our program with Memorial Park and other facilities. When a patient comes in, obviously, you know, it's the first step is going through detox. You know, once they are chemically stabilized, we quickly begin the discussion about the importance of being able to feel your pain rather than blocking your pain. We have this idea of having patients start making a pain journal and have them actually describe their pain throughout the day. You know, oftentimes chronic pain patients, they're so disconnected with their pain sensors, with their pain sensations. They can't tell you, you know, where they hurt, how they hurt. They just know they hurt all the time. You know, so first step we do is get them to reconnect with their pain sensor, coach them through how to tell the difference, the variation of their pain throughout the day. And then from that journal, we guide them through step by step on how to modify their behavior and how to modify their thought process as well. As you all know, perception of pain is highly driven by emotion. You know, their anger, their fear, you know, that is a contributing factor to how the pain is perceived. And so if that is not being addressed and that's not being, you know, discussed with the patient, they're often mistaken that physical pain for their emotional pain. And so it's a long process of coaching people through, connecting with them, and at the same time, as a pain management doctor, I also look at their pathology, their pain generator, and some of them do have pain generators, and we walk them through the pain management protocol, looking at their MRI, looking at their CTs, and take them through therapy and so forth. But it's a long process. It's not something that, you know, we can prescribe a medication and get rid of it for sure. It's a long process. Some people do come back and they do have, you know, exacerbation here and there. Some of them do have to go to have any procedure done, and a lot of them have to be on opioid for short periods of time. And you know, we coach them through how to get through that post-op acute pain phase and get them taper off and get back into their recovery again. So we've been blessed to have the opportunity to work with Matt for the last 3 years at Park to develop a program like that for opioid-dependent chronic pain patients.
You know, one of the other things that I'd like to mention on that is that when we started that program, the idea was to be opioid-free in terms of treating patients with chronic pain and addiction. And the program has been able to maintain that stature. And the reason is most of the people who come into the program are polysubstance dependent. Opioids are one drug that they take. And there's alcohol, of course, is a big part of it for so many people. But there's benzos, there's muscle relaxers, there's other drugs. And everybody here, I know you know what the Holy Trinity is, right? Vicodin, Soma, Xanax, right? Okay, those three together, and you can interchange certain names and so forth. But the person who comes in, a lot of times, that is their gateway to what is triggered or set off the road to addiction for them. It's not they started off on other things and moved to that. For a lot of people, it might have been that injury, it might have been that surgery, it might have been some other thing that occurred that had them taking opioids, and that was the triggering mechanism, and then the addiction came with that as a result and went from there. And then the protection people go through to say, you know, well, I'm not really an addict, or I don't have an addiction. I got this way because of my injury or whatever, and there's a justification that's always going on, a little fight about, you know, why we're in this state or why we're in this place. And it somehow makes it okay, and that I don't need to address it, I don't need to treat it. And so a lot of times the conversation with patients is meeting them where they're at and opening them up to that. I think one of the fantastic things is when you start blending various approaches that are not always about a medication of any kind, but you're using physical therapy, you're using acupuncture, you're using mindfulness, you're using meditation, you're using other forms of interventional strategies. The cool thing is for patients is they start to wake up, they start to open up. And I think all of you know from your work in this field is when you detox someone, you bring them through that which they've been dependent on, and you get them cleared and you get them able to focus, and the fog starts to lift, and you're working with that, and you're also addressing the pain at the same time, and you're honoring that pain and you're valuing that. You're not dismissive, you're not saying it doesn't exist. But what you see is people start to have hope, and they start to want to work with you and try these different approaches, and they're willing to do that. They're willing to do something different. And when people come into treatment who have suffered with pain, when you ask the pain scale questions, they'll generally tell you 8 to 10. That's usually like where they're at when they come in. By the time they leave treatment, it's 0 to 2. Is that because in the treatment setting you're a miracle worker and you're that good at alleviating the pain? Maybe. But a lot of times it has more to do with the fact that you've kind of cleaned the slate. You've cleared it all off. You've given people some hope. You've given them multiple levels of interventional tools to work with a biopsychosocial spiritual approach. You've given them a combination of things and good medicine to boot. And you've been able to help them see a way out. And of course, that might even lead to another question. If you've heard of the term hyperalgesia and how that works, we know that opioids are good for a shorter duration. And I know you mentioned about acute pain, but a lot of times when people get in trouble, that's because they've continued to use them for a long period of time and they lose their effectiveness. And therefore, our answer is you take more and more because it'll be more effective the more you take. And a lot of times, as I've mentioned, if you go ahead and take enough of anything, it will numb everything, and then you will feel better. So on that note, I would like to ask the members of our audience here, if you have some questions or thoughts or things that you would like to ask the panel about, I'd really like you to feel free to ask. You know, I can go and look for canned questions and all that, but it really is about you're here. What are some of the subjects you have that related to opioids and medication-assisted treatment and pain and chronic pain and just the crisis in general and how we're addressing it as a country and as treatment providers? Is there any if you have some thoughts or questions, I certainly would like to hear them, and our panel will be happy to address them. So, yes, ma'am.
You had mentioned two different things, two different interventions.
Yes.
Rolfing
And osteopathy.
osteopathy. Would you be able to explain a little bit about
Well, they're
those?
both manual manipulations, different than chiropractic. And Dr. Lai mentioned pain generators. People